Members of the committee, thank you for the opportunity to offer testimony in opposition to Senate Bill 23. My name is Angela, and this is my son Ezra's heartbeat. This is the only way I will ever hear it, as I had an abortion at 17 weeks and 3 days. This tends to confuse people because they don't recognize that many women who suffer fetal loss require a procedure to remove the fetal remains in the placenta, and that procedure is an abortion. I am grateful that I was compassionately offered multiple options, and I chose a medication abortion. Misoprostol allowed me to deliver my son's body intact. I was able to hold him, as was my husband and our 3 other children. We were able to cremate his remains. To the individual here who is an abortion doula, thank you for the work that you do, because I would not have survived that without the nurses there with me to help me deliver. Now, while Senate Bill 23 does allow a physician to perform an abortion if there is no heartbeat, such as my situation, this assumes that any physician would be willing to perform an abortion at all, with the strict regulations and the high stakes of losing their medical license and a felony charge. Women like myself losing necessary medical care is just one issue I have with Senate Bill 23. Senator Rogner, you stated in your sponsor testimony the most devastating thing a parent can hear is that there is no heartbeat. No, ma'am. The most devastating thing I could have heard is that there is no longer a heartbeat, and you must now continue to carry your dead baby. And what will happen is that his soft tissues will dissolve inside you, and his bones will calcify, and he will not be recognizable by the time you reach full term and we are finally able to induce you. I first have a few technical and constitutionality concerns with SB 23 specifically, followed by concerns with abortion bans in general. And then finally, as a registered nurse and a graduate student of public health policy, I do have some evidence-based solutions to offer that this committee might consider if a reduction in abortion rates is truly the goal. On Senate Bill 23 specifically, it is clear that the sponsor did not seek input from medical professionals because the 1999 study that's quoted is outdated. It's not generalizable, meaning that it looks at a specific subgroup of women suffering recurrent idiopathic miscarriages, and those results cannot be applied to the general population. She grossly misinterprets the meaning of the test statistic, which identifies gestational benchmarks in which a physician can offer additional reassurance to patients who have suffered miscarriages in the past and the likelihood of them carrying to term a subsequent pregnancy. If we are going to mandate that physicians counsel their patients, we should at least be certain that our information is true and accurate. We should also counsel women on the likelihood of maternal and infant mortality, which is abysmal in Ohio, at 42.8 and 720 per 100,000 respectively. In fact, a woman is more likely to die from pregnancy and childbirth than an abortion procedure. We should also individualize our counseling because women of color are 3 times as likely as white women to suffer both, a health disparity Ohio has failed to address. The sponsor testimony attempts to assert that we have no clear definition of viability and that medical advancements make viability a moving target, which justifies this ban. This is false, as the Supreme Court has provided a clear definition of viability as, quote, potentially able to live outside the mother's womb, albeit with aid, end quote. Medical advancements were also addressed in 1992 in Casey, which is why states today can set the point of viability, and it varies state to state. On abortion bans in general, we have a robust history that demonstrate bans help no one but hurt many because they fail to address the primary contributing factor of abortion, which is unintended pregnancy. Bans tend to have the opposite effect because restricting a woman's access to reproductive health care increases unintended pregnancies and therefore abortion rates. Countries with strict abortion bans find them impossible to enforce. While the sponsor testimony focused on prosecution of the physician, the bill itself does not limit the felony charge and uses the terms person or individual throughout, which I interpret as applying to the pregnant woman herself. Will we now investigate miscarriages like mine? Will we rely on doctors to report their patients that they suspect of attempting a home abortion with the readily available and inexpensive misoprostol? This medication can be shipped to our doors faster than the fentanyl Ohio has still failed to prevent entering via the mail. While I appreciate the inclusion of the medical emergency exemption, we need to be honest that physicians will be unwilling to risk the loss of their license and a felony charge when faced with the following. A woman carrying twins, where one is failing to thrive, threatens the life of the second. SB 23 dictates both twins will die. Now who is playing God? A woman with a severe mental illness who takes medication that is not compatible with a pregnancy. Do we force her to carry while those teratogenic medications kill or severely harm her child? Or can the state force her to stop taking her medications? We can just strap her to a bed in an institution until she's ready to deliver. A woman with cancer, is this an emergency? Or is waiting 9 months and the increased risk of her morbidity and mortality not enough of a threat to her life? These are not hypotheticals, by the way, these are real cases. When the regulations are so strict and the stakes are so high, that illusion of physician discretion is a moot point. The practice of medicine is highly individualized, nuanced, and it operates in the gray all of the time. We have a medical board and a nursing board for this reason. Legislators simply cannot dictate medical practice. As a graduate student of public health, I do share the goal of reducing abortion rates. I have evidence-based solutions to offer. One very specific example comes from South Carolina. They made a minor change in their Medicaid law that allowed an OB to place an IUD in a patient during an inpatient postpartum stay, rather than having to wait until her 6-week follow-up appointment. That reduced that group's abortion rate by 50% by just that simple change. More generally speaking, though, universal health care, the best thing Governor Kasich ever did for reducing abortion rates was the expansion of Medicaid in this state. Access and affordability of birth control, specifically long-acting birth control, which is more effective. Investment in non-hormonal birth control options and male birth control options. Comprehensive sex education, which Ohio still fails to deliver to our high school students. Livable wages and equal pay. Affordable housing and childcare, paid maternity and paternity leave, et cetera, et cetera. You heard a lot of talk of heartbeats from proponents, but I hope you will remember Ezra's heartbeat and recall that healthcare is too personal and nuanced to be legislated, and that solutions do exist in order to lower abortion rates, but Senate Bill 23 is simply not one of them. Thank you.